into account the likes of disability, learning. A lot of people may not be able to read or write just because we might kind of know what the best is for people. People know the best for themselves. So it is, and that is how we entrench our care with dignity. Does that answer your question? Does that answer your question, is it? It's...
I'm just wondering, because I 100% agree with Julianne, but I think a huge part of the work that we also do, besides the work that we do with the Global Mental Health Peer Network, is around third world countries. And I think because I'm based in South Africa, I've experienced it a lot of the time where there isn't a culturally fit person that is going into communities and actually working with the women, children, individuals in the community. It is often, in my experience, and I just want to say that quite loudly, westernized, the care and the way things, and my word that I was thinking was exploitation that often happens with the research. So I'm a massive advocate for when it comes to learning from individuals that often come from areas that there is extreme poverty, where they have no other option but to go with the research because they're so desperate, and I call it guinea pigging, because there isn't another option for food or transport or anything. So once again, I think it then looks at a political view as to the research, as to why it's happening, as well as a cultural fit. And going in with somebody that's actually a cultural leader or spokesperson for the individuals in the community, and kind of going from the bottom up instead of doing the top-down approach. I don't know, does that help?
It's a tension. That's a tension that I hold a lot in my work as well. So this tension between, the desire and the necessity of working from the bottom up, and actually what that means to work in places where there is nothing, like this, where research is the opportunity for lots of different things. And I think for me, a lot of what was said, what you guys have been saying, that resonates for me about how we sort of not ensure that that's genuine, but like it's actually a trust in the fact that people are good in the first instance, that people have passion, like people are passionate about these issues when they do come forward, when they engage in it. And I guess it's about thinking about how we might, in research or co-production, or that is co-produced, and intervention development that is co-produced, think about multiple different ways in which we are negotiating and collecting different types of lived experience, and think about how we might, by diversifying that range of how people are involved and where they're involved, that actually that takes account of the different ways that people might not just benefit from this opportunity in sort of low resource settings, but also ensure that people are contributing in the ways that feel most appropriate to them, which then reduces the likelihood that people might be pretending to be a part of it. That's this idea that people might be pretending about something. But I think ultimately what we want to do is that by you acknowledge the political environment that we're working in. It's so important. It's so nice to hear somebody talk about politics. I'm not surprised to happen in the co-production section. But this is, the political landscape. That is such a huge, important piece of how research is negotiated, how it happens. And working with people who have understandings of that context, as well as creating lots of different opportunities and pathways to participation in research about mental health, about recovery, ensures that I think that doesn't happen. At least that's how I've heard it.
I just want to add on, and you guys can totally cut me off. I'm a chatter. But I want to say I think another part of it is outcomes-based, and really measuring what the outcome is for the research, in the sense of leaving a legacy instead of collecting data, dropping and running. Because I think that often also happens. Yeah. But thinking of a long-term outcome for the individuals, where there are actually people in the community that can stay and hold space.
Yeah. I think we should leave it there. I think I've reclaimed enough time that we lost this morning from the other panels. Just a huge thank you to all of our speakers and presenters. Thank you for your wonderful questions, and enjoy the rest of your day. Day 3 already. I don't know how that's happened. Thank you so much.
We'll be starting the next session in just a couple of minutes. If I can have the presenters come to the front of the room, thank you. Hello, everyone. If you could please take your seats, we're going to go ahead and get started. Thank you for your patience. Welcome to our next session for today. The session is on best practice models in policy and law, a call to adapt. I will be your moderator, Taylor Locke. I am from the United States with Aves Mental Health. Our first speaker for today, for this session, is Ragnold Dibal from Africa CDC. Thank you.
Thank you very much, and still good morning. So I'm not Adelard Kakunze, who is supposed to do the presentation, and I apologize that I'm not Adelard. I will do my best to represent Adelard and the rest of the authors. My name is Ragnhild. I work for Africa CDC. I'm seconded by the Norwegian Institute of Public Health. My name they gave up on day one, so they just call me Rags. This project is ongoing, meaning that hopefully there will be time for questions and comments, and I'll try to stick to my 10 minutes. And I'm very motivated to do that because this is an ongoing project and your input will be very valuable. The aim of the study is to provide an overview of the existence and gaps in governance documents in member states, so that to be used to plan and guide activities and interventions to support the member states in their development and use of such policies, strategies, and legislation. There's a whole team of us working on this. You can see the names here, and I'd like to acknowledge in particular Prof. Taiwo Sheik, who's been the leader of the project, and also Ms. Mai Richter Svensson, who's done a lot of the background work. Why do we do this? Why do we focus on policies, legislation, and strategies? Well, because this is core in governance, and therefore foundation for financing, for application of good evidence, for the development of mental health workforce, and in fact one of the important foundations for a whole mental health prevention, promotion, care and rehabilitation. Also, legislation and policies have a normative role in that it signals what do we mean by, or why is it, what does it mean, what values does it have, that is another reason. And also, as some of you may be aware, the flagship for mental health in Africa CDC is the Mental Health Leadership Program. In the leadership program, we have increasingly, I think, become aware that legislation, policies, strategies really are core, whether people are in the leadership program to develop leadership skills or to advocacy skills. This connection to governance is very important. And finally, there are several recommended action on legislation and plans and strategies for member states that we lean on, including the Mental Health Action Plan of WHO and our own strategy on NCDs, injuries, and mental health at Africa CDC. And so, if this is so important, isn't it already done? Well, to some extent it is already done, and to some extent there are already good tools available, which we build on, use, and try to complement and deepen. In view of my remaining 7 minutes, I won't go into details of these tools for information and collection of data, but just mention them here, and you can have a look. One of the very important tools that we really try to lean on is the Mental Health Atlas, which is a very, very valuable tool and resource. But there are also several others. The Mental Health Atlas, well, I think it's the 7th that was just released this year, the 2024, has a lot of very good information on the state of all countries, or nearly all countries, when it comes to mental health and mental health indicators. Some of the indicators, some of the data that's particularly relevant for this study have to do with the existence of standalone or integrated policies and mental health laws, the degree to which these are aligned with human rights, or the degree to which they are implemented, have financing, to which they are in the process of being implemented, etc. So there are lots of these, and we're not doing exactly the same, but we're trying to take the existing data into account and build on these. In the atlas, there's also information about the degree to which countries have collaboration with stakeholders groups, including civil society and organizations representing people with lived experience. So what did we do? Well, what are we doing? One of the important things is a desktop review, trying to go through what's already available, and also to do what we always do in Africa CDC, is to work with member states. And Prof. Taiwo, who's an expert in this field, really includes also the focus on exploring and explaining to our partners what is meant and what is the difference between the various documents and policies that we're talking about. There's also a quantitative survey and qualitative interviews more in depth, and we're also, as part of the desktop and in between here, doing some in-depth case studies. And then towards the end, before dissemination, we'll also do a feedback session. From the desk review, we found there's a lot of interesting and valuable literature as well as data and published articles. Here, just 3 good examples from various contexts, from South Africa, from Cameroon, and more general. And this conceptual and in-depth literature is very valuable. Here's some of the, this is an example of finding from the most recent Mental Health Atlas, where you can see the existence of distinct mental health policy or plan in the most recent ones. And in 2024, as you can see from the Afro region, there are 25, so 74% that have a distinct mental health policy or plan. And we've gone through from our desk study, from our work, to try to make the overview of countries with the various documents. And here's the first finding we did, was just going through all countries in a sort of yes or no. Then we moved on to policy and plans, as you can see in the first column for all countries, and legislation in the second column, and when these were last updated. And here's this region by region, so East Africa region and South Africa region you can see here, and then you can see the percentage at the bottom of countries in that region that has none, so no policy or plan or no legislation. And here is from West African region, Central African region. So from Central African region, it's a very high proportion that do not have legislation, mental health legislation that is distinct, but much lower that do not have any policy or plans. And this varies a lot from region to region, and you can see also legislation update and policy update also varies in time from here. Just a couple of glimpses from the case studies from Guinea, Sierra Leone, and Mauritius. We chose these because the first one had neither. So it's one of those examples, no standalone mental health policy, no standalone mental health legislation that we could find. And Sierra Leone has a standalone mental health policy, but not legislation. So what does that mean? This is where the project gets more interesting. What does it mean in practice? That they do nothing, or that we have missed it, or are they in the works, and what are we actually talking about? So have gone into more depth here. So in terms of Guinea, you can see the policy. There's only a description of current mental health challenges, which is part of the national multi-sectoral strategic plan for NCDs. And in legislation as well, it's mentioned in the Public Health Code from 1997, where it actually does say that mental health is a priority. So it's much more than nothing. And Sierra Leone, similarly for the policy, we found a lot of various information. And I'm happy to share our findings in more detail anytime. Here's more information on Sierra Leone. I think this nuanced and more in-depth information really adds to it and then starts for the next phase of the project. The Sierra Leone legislation is actually still the 1902 Act, categorizing people with mental health issues as criminals or victims of witchcraft, is what it was said. We also found mental health being referred to in other legislation, including suicide as illegal. But we also found interesting plans for the Ministry of Health on a new mental health bill that shall replace the old act. So finally, we've been trying to look into facilitators, such as political will, investments, including in some countries the special initiative of mental health by WHO, or collaboration with other partners. We found particular barriers, but this is something to be explored and something where we'd be happy to have your input. We found the role of civil society and of organizations representing people with lived experience being one of the important factors. And we are working on how to use this knowledge to support member states in the development, use, and implementation of policies and legislation. We're doing this built on another model on mental health and psychosocial support in emergencies, where we've had for a couple of years now on work where we gather countries, African countries together in the region, where they learn from each other, share experiences, and hopefully we will be able to do a similar thing based on this. We also want to integrate this knowledge even more into the leadership program. Thank you very much.
Thank you so much for that excellent presentation. And I also just want to thank all of the presenters for being mindful on time. I know 10 minutes is such a short window, especially when you're presenting research and it's so complex. So thank you for that. And I look forward to us being able to discuss that presentation as well as the other ones during the panel session at the end of the session. Next, we will have Julianne Cullen from Ireland with Aves Mental Health, as well as Parth Sharma with Sangaf and Aves Mental Health from India. Thank you.
Hi, my name is Julianne. I'm from Ireland, as Taylor lovely introduced me, and I'm a member of Aves Mental Health as a lived experience.
Hi everyone, good afternoon. My name is Parth. I am a person with lived experience as well. I'm here on behalf of Sangat and Aves Mental Health.
So this piece of research that we have been working on for the last 2 years involved a timeline that actually we identified this conference first, before we even began to work on what it is that we were going to research. So being here is a huge achievement for us all, and we're very excited to share our findings with you. So Claire Brooks, shout out to her, because she has been a mentor and guide for the last 2 years, keeping us on track. And there was a collaboration between Ava's Mental Health, the Mental Health Global Network, and the Dignity Project to look at the WHO's new guidance on the rights-based guidance and checklists. So to make sure that human rights were going to be measured and be accepted in mental health services. So we know that there's no health without mental health, but we know that stigma, discrimination, coercion, and lack of access to quality healthcare are significant barriers. So we decided to look at the checklist of items to ensure rights-based practice and calls for feedback on barriers faced by people with lived experience. So we decided to collaborate together, and we identified the research aim. So we knew that there was a critical gap in understanding how these very kind of high-level recommendations translate in real-life experiences of service users and across a diverse cultural and system context. We know that not every shoe is going to fit everybody, that there is very, very different approaches that are required for in comparison to different income countries. So it is the first systematic empirical research. It's ongoing, so we're still kind of working on it. And we explored this guidance document from the perspective of lived experience from the very, very get-go. We had a research proposal that Larry White put a lot of work into, and it was very difficult. We had to get it accepted, but we did, fully led by lived experience. And we are aiming to identify the perceived institutional and social barriers to implementing rights-based legislation and mental health care systems and outlining that publication. And we're looking at the impact that these barriers have on the lives of mental health care experiences of the service users worldwide. So how we did it. So we had a community-based participation research, and we had that led by people with lived experience internationally. We were looking at the challenges of traditional research hierarchies by positioning service users as co-creators of research about themselves. So we used a mixed method approach. We used structured survey, which participants rated the importance of the 33 barriers that were listed in the guidance document, and we used a 5-point Likert scale. We then used from that survey a semi-structured focus group discussion to understand the impact of top barriers of people with lived experience, the purposive and snowball sampling through the Mental Health Global Network and the now newly AVAS networks. We used data collection, which was from March to June, with 56 completed surveys from 18 countries across 6 continents. There were 6 regional focus groups, and there was 18 people in total. So the participation demographics you can see from our graphs. There was 56 people completed from 18 countries and 6 continents. It demonstrated a significant diversity in sexual orientation, and the age was from 25 to 34 as the primary respondents. So these are our top 10 most critical barriers. So we started with 33, Then from our survey findings, we used the top 10 to be the focus of discussions in our focus groups. So as you can see that there is the most highest would be the likes of stigma, finance discrimination, training, lack of rights, using deinstitutionalization. So we can see that there, regardless of where we are in the world, that people are sharing the same barriers. So I'm going to hand you over to Parth, who's going to talk about our qualitative part.
All right, so what we did here, on the face of it, we look like, okay, this is standard research, but what was one of the most difficult things about this project was that we wanted to do this in a way that is completely owned by people with lived experience throughout every single step and create trauma-informed protocols at every single design aspect of this as well. So if you attended the last panel, in fact, one of the papers that Julianne and Elsa are presenting were discussing the methods of this particular project as well. What we did with the qualitative analysis was that we conducted a framework analysis. Since the WHO has already created a checklist with the 33 barriers, we already knew what are the thematic areas that they're looking for feedback on, but we also did keep scope for additional feedback that is coming up through the survey and also through our qualitative interviews as well. We identified these as the primary key barriers: stigma and discrimination, access to quality, culturally sensitive mental health care services, transition to community-based services, deinstitutionalization, and respect for legal capacity, informed consent, and elimination of coercion. We're going to start with the first theme, and you're going to see, at least in the first theme, when I talk about stigma and discrimination, there's a discrepancy between both the LMICs and high-income countries. It is because while stigma is prevalent across all regions, it presents very differently in policy and experiences of people with lived experience. In low and middle-income countries, stigma is often overt and dehumanizing, which means, for example, the participant from Indonesia has put it really well. They said that this is a mental patient, crazy I heard, hey, don't, who are you? Is how they talk to people in Indonesia when you're going out to a primary health setting. And this is also the people who have access to these primary health settings. At the same time, in high-income countries that we did our focus groups in, we saw that stigma is both covert and overt. However, it is far more covert in terms of refusal to participate in services, service delivery as well, where a participant from Ireland said, when we were introduced to the unit psychiatrist, she said, I've heard this name, and she walked off. When we're talking about access to quality, which is the second theme of the larger key barriers that we've identified, we saw that across all the regions, one thing was standard, that mental health and physical health is not treated in the same capacity, either in funding, coverage, quality of services, and frankly, even policy. So when we were talking to the participants about the experiences, they told us, yes, this doesn't matter whether you're in the UK, US, Ireland, or you're in Indonesia or Nigeria, these are the same things that are going on every single place. Mental health is not covered by insurance in Indonesia, and what a striking thing. To cost one session with a psychiatrist or a good session with a psychiatrist in Jakarta, you could potentially pay 10% of your annual salary to get that appointment for one single session. At the same time, here in South Africa, someone wrote that in Limpopo, where they're staying, you'll find that there's only one hospital in the big area, and some of the mental health care users go back home without getting any medication and end up relapsing because of the same fact. In terms of the next theme we saw was, again, the idea of deinstitutionalization, community-based mental health care, and also effective support for peer-led services. This is how the WHO and the UN have quoted these terms across the entire checklist as well. What we saw was across all the regions, there is resistance from medical establishments and NGOs to develop community-based services, including peer support. Peer support workers are often assimilated within the organization, formalized, and denied any capacity to provide feedback. So the moment you're critical of the services that you're assimilated into, you're automatically bullied or thrown out of those spaces as well. They're also poorly compensated, overburdened, and suffering burnout. It is also important to note that many also brought up the idea of community health workers and the idea of them being overworked in this context as well. Again, one of the participants from South Africa wrote about the whole manufacturing idea of the mental health industrial complex, where it feels like the moment you get in the service, you get A, B, C, D done to you, and not with you within that space as well. I'll give it a second for you to read that quote. I can also read it out. Everything is like we need to admit you, and then we can do A, B, and C. And that's the production line part that I was talking about, because there's more money where institutes get involved than to treat a patient as a standalone outside of those institutes. A very telling commentary on the whole mental health industrial complex here as well. The fourth theme that we saw was respect for legal capacity, informed consent, and elimination of coercion. Here, it is also important to note that while we know explicit coercion exists and there is policy and laws around that, what we got really strong opinions on were informal coercion in these spaces. Informal coercion and the soft coercion where you're coerced into saying yes, you're coerced into not having an opinion, or you're not provided an opportunity for continuous informed consent in your own care as well. Here, the participants across the study described the healthcare providers as not listening to them, mocking and demeaning them, instead of treating them as experts by experience within this space. Here, I'd really like to point out today, given the political scenario where we are in, look at the statement from the participant from the states that says that I hear that all the time people have court audit sessions. If you miss it for any reason, or if it's not working, there's no way to get out of it. You have to attend these sessions, and you're getting something that really doesn't work for you, and that can really damage you as well. The idea of state sanctions, psychotherapy, state sanctioned psychiatric sessions, and the harm that it causes people with lived experience in high-income countries like the United States of America as well. When we talk about the larger recommendations of what's coming out of this, before I go into what the participants identified, and also in complete disclaimer, this is an ongoing study, which means that this is what we've just done right now, and these are preliminary findings that we're sharing with you. I'd like to read out the quote and a testament from a participant from the UK, who said that, "I've never been asked for my feedback, and that's a fundamental right. I should be allowed to share my opinions and my experiences without getting stigmatized or punished. If you're not asking those questions, that's quite honestly, you don't value us, and that's a human rights issue right there." This was in commentary to the larger NHS system in the UK, and the idea of, again, people with lived experience not having any formal feedback redressal mechanisms for the harm that they're going through at an institutional level. The participants identified resource allocation reform, professional education, insurance system reform, community infrastructure development, and crisis system development as some of the themes. It is also important to note here particularly that while the 10 top barriers were identified, the participants from the focus group added far more nuance that is not in this presentation as of now, and we're also synthesizing those results. What does it mean to have decolonized? What does it mean to have community-centered care? What does it mean to be culturally oriented in countries like Indonesia, in countries and smaller regions in South Africa, where care like this is not the right option for most people? With these recommendations, what we're doing is now creating a response to the WHO. One of the things that we were also focusing on with this larger project was how do we hold organizations like the World Health Organization and the UN accountable for creating these measures? You can create them in silos, you can create them and disseminate them across all your regions, but if people with lived experience do not respond to them, do not critique them, do not provide you with the feedback, then are we really doing this for the people as well? Alrighty. With every research, there are strengths and limitations. We also recognize the fact that we did this with a community-based participatory approach, so we were very proud of the fact that as an unfunded project, as a volunteer-led project by people with lived experience from across the world, we started out with a team of more than 20 researchers and had attrition down to 8 because of everyone's capacity and the privilege of being activated to do research. So we were really proud of the fact that we could pull community-based participatory research off. We were also very proud of the fact that we had a global and diverse sample. This is not to say that we did purposeful sampling through our own networks, so there may be overrepresentation from those who are already within the network of Movement for Global Mental Health and ours mental health here as well. One of the things that was the most unique thing to this project was that we designed every single tool in the languages of the countries that the focus group discussions were taking place in. So the researchers and people with lived experience not only conducted those focus group discussions in their own language, the framework analysis and thematic analysis was done in their own language, retranslated back to the larger team, and added here. So the idea of reflexivity, cultural reflexivity, the idea of power dynamics are all being noted. So I'm very glad that you had an opportunity to listen to the presentation earlier as well, which talks about dignity in projects like these, in co-production like these as well. So we're hoping, this is preliminary findings from this research, and we're hoping that when we move forward, we're able to share this feedback with the WHO, hold systems accountable, and actually make sure that these policies translate into the community as well. We'll definitely like to acknowledge all of those 20+ researchers who started out with us. We had a lot of people for the first time ever going on a research project. So they were designing the IRB form, the institutional review ethics form. They were designing the proposals from scratch. So we got to do peer-led trainings for each other. We got to do capacity strengthening sessions for each other. And we really got to see what empowerment looks like over the course of the 1.5, 2 years that we've been doing this project for. We'd also like to thank Zach, who is running around. We tend to forget the invisible labor of people who work behind the scenes in scheduling these meetings, ensuring that resources are shared with each other, and making sure that everyone has access and accessible communication during projects like these. So we'd really like to thank Zach and everyone else who participated. Thank you.
Thank you so much for another excellent presentation. Our last panelist for today is Mia Atoy from Embrace in Lebanon. Thank you.
Thank you. Good morning, distinguished delegates, colleagues, and friends. As I stand here, a few thousand miles away from home, Lebanon, which is a small country in the global south, my mind is divided between the privilege of being here, engaging in this global dialogue on innovation, equity, and compassion, and also the unfolding reality back home. As I listen to our inspiring discussions about building brain capital, about how lived experiences are meaningfully shaping and transforming mental health care delivery across the world, and how we are reimagining investment and financing for mental health. And as I move from one hall to the next, there are some words that unfortunately are missing from our sessions. And some of these words are political aggression, structural determinants, and geopolitics. The forces that so often, unfortunately, make the work of mental well-being pursuit almost impossible. And the reality is that I glimpse every few minutes between the stage and my phone in my hands, and I read more notifications, names of villages that are being bombed, including my own hometown, WhatsApp messages from our mobile mental health teams on the ground, checking roads and safety, and deciding whether to continue their work on the field or go back to safety. At the same time, families are still fleeing from their half-built homes, once again, in search of shelter. But this time, all of this is happening with no media coverage, no humanitarian response, and no international support. This juxtaposition between standing here on the stage, glimpsing back on my phone, and between policy and lived experience should, I believe, be at the core of our conversation on global mental health. And this is a reminder, perhaps, that we're not doing enough of that. Because conversations about brain health and cognitive ergonomics, which, by the way, is a term that I learned here yesterday, cannot be detached from the structural violence and political aggression that are continuously undermining them. Exactly 1 year ago, Lebanon witnessed one of the fastest mass displacement in modern history. Within 48 hours, 1.2 million fled their homes as the war escalated. Within 2 months, 4,400 people had been killed and 16,000 had been injured, including 167 first responders who were targeted while performing their humanitarian work in clear violation of international humanitarian law. But these, unfortunately, were not Lebanon's first wounds. The country has already been staggering under a severe economic crisis since 2019, the Beirut blast explosion in 2020, and of course, the lingering impacts of the pandemic. Like many countries we've heard about in the past few days, we also face a severe shortage of mental health professionals and severe inequities in delivery of care between urban and rural areas. The most recent data as well is quite alarming from the country. 3 out of 5 Lebanese today are screening positive for mental health condition. And this is a dramatic rise from the 1 in 4 statistic that we reported 2 decades ago. Despite this compounding adversity, Lebanon's mental health system has still demonstrated remarkable resilience. Even under bombardment, the National Lifeline for emotional support and suicide prevention continued to remain active 24/7, staffed by youth volunteers, many of them who were serving even after losing their own homes. Our national mental health emergency mechanism teams more than doubled their field deployments, delivering critical and life-saving psychiatric care to displaced families in overcrowded shelters. And clinicians worked under fire. ensuring the continuity of psychotropic medication and treatment for displaced individuals who were already living with chronic and severe mental health conditions and who had to flee their homes without their medications. I speak of this not as humanitarian aid. This represents the harvest of years of health system strengthening that we have been doing back home, cross-sectoral collaboration between civil society organizations, academia, and government to build the kind of structures I described here and that are capable of enduring even in war. However, unfortunately, conflict inevitably tests our systems, which were not supposed to be built and to function under bombardment. And these contexts do offer lessons for the global community and for us here today. Our recent publication, Adapting Psychiatric Practice in War Zones, documents some of these experiences and provides some evidence on how psychiatric care can and maybe should evolve under extreme conditions. So this is a little bit of what we have learned through our work. We learned that war forces us to rethink ethics in real time. Our clinicians were addressing acute mental health needs in overcrowded shelters and had to choose between ideal ethics and immediate care. Privacy, confidentiality, safety, preserving dignity, all of these, which are the cornerstones of our medical practice, were impossible to uphold. In these moments, we redefined our do no harm oath into doing less harm. That principle on its own, which was born from necessity, should make us rethink global humanitarian psychiatry frameworks. Our training, unfortunately, rarely prepares us for these moral tensions. And from this, there is an urgent need to institutionalize crisis psychiatry curricula globally. We need to start equipping our mental health professionals with the knowledge to make ethical and clinical decisions, not only in the safety of the private clinic, but also in unstable environments, and to learn how to integrate crisis communication, humanitarian ethics, and community-based intervention as part of their core competencies. We often discuss task shifting. I heard a lot of those conversations happening between these halls, but in conflict settings, do we need to reconsider reverse task shifting, where specialists must also be equipped to deliver foundational psychosocial care when needed, as we witnessed? We also learned that stigma, my colleague was just talking multitudes about it, which is already pervasive in times of peace, does not disappear in times of war, but it deepens. Even in crisis, many people we saw feared being labeled crazy or weak. Our clinicians adapted. We reframed mental health as coping with stress, as managing fear, and adapting in crisis. No, we did not use words or diagnoses or labels, but focused on things like sleep, loss, and resilience. Gradually, what we noticed is that the individuals who we were seeing in shelters began to slowly seek and request follow-up sessions, and even advocated for other displaced individuals to seek mental health care. Now, that shift from silence to agency reflects the global mental health agenda of mental health literacy, when communities really begin to understand that mental health is part of daily life and not a mark of shame. And remarkably, we were able to do this even under the bombardment. What we also learned that war magnifies the role of culture and faith and how distress is expressed and healed. Many describe their suffering as a test of faith or divine punishment. I really stood for a few minutes when a displaced person said, "If this is a test, God, I'm failing, and if it's a punishment, what did I do wrong?" Clinicians, in the face of these kinds of statements, adopted, of course, a culturally sensitive approach, framing faith as a source of resilience rather than a barrier to care. This is at the essence of context-sensitive care. healing that aligns with cultural and spiritual realities. But again, this is not part of the core curricula of mental health professional training programs, and we don't see this being implemented often. Finally, I would like to highlight that our work also extended and our learnings also extended to the well-being of those providing care. And we did hear a lot of that over the last few days. Our clinicians were both healers and survivors. Many of them lost homes, family members, and were also displaced alongside the patients that they were seeing. We learned that caring for the caregiver is not a luxury, it's a public health necessity. As one of our psychiatrists and team members marked, you cannot ask people to stay calm under fire if you haven't found calm within yourself first. The duty of care for mental health professionals must be institutionalized through supervision, peer debriefing, rest protocols, financial incentives, and psychological support systems that can prevent moral injury and burnout. Finally, our experiences from Lebanon really underscore several global policy implications that I hope we can work together on and learn from the summit and other summits to come. First, the importance of integrating mental health into national disaster preparedness. Fortunately, we had begun to start doing part of that in Lebanon, but still it was not enough. And also, I would like us to also consider integrating this into our global policy dialogues as well. We need to invest in crisis psychiatry curricula more, equipping our professionals with the knowledge and competencies to navigate ethical, logistical, and cultural challenges in humanitarian context, and not only within private settings. We need to work on enhancing cultural competence and contextual sensitivity in all global training frameworks, and to institutionalize really the protection of our mental health workforce. Finally, I hope we can make use in future summits of more South-to-South collaboration to create mechanisms for our countries to share expertise from Lebanon to Gaza to Sudan, and allow us others to also learn from the indigenous models of care that we are developing under crisis. Before I end, I want to share that even though my talk today was about the war in Lebanon, this is not a humanitarian call. This is not a humanitarian talk either. It's about how we have built human rights-based systems and about peace building. We learned that delivering mental health services rebuilds trust, restores dignity, and allows us, maybe, just maybe, to imagine living a future without violence. Lebanon's story is really one of leadership. It shows us that innovation is not the privilege of living in a stable country. It is the practice of perseverance, and that mental health should not be an afterthought in war, but it is actually the architecture of recovery. Thank you.
Thank you so much. Such a powerful presentation to finish off our session for today. At this time, I will ask all of the panelists to join me on the stage, and we will open up for questions.
Everyone, thank you so much for the interesting presentations. I had a question for Mia. I'm at the American University of Beirut, as you know, Mia, and I was wondering about your reverse task shifting, which seems so key in our context. And I appreciated your ideas around how we might do that. And one of the things that I thought is around this curriculum or a way of integrating it into our program. So, for example, in AUB, we have a tendency to model our programs and our training programs for clinical psychologists on US norms and content. And so, of course, we're delivering it, and so we're going to contextualize it as we're delivering it, but still, the structure is very much based on the US and Europe. And so, would there be ways, I guess, to shift and integrate what you're describing structurally into those programs in AUB and other training programs in the country? Thank you.
Thank you, Tanya, for that question. Yes, there are two problems in what I presented and what you're also mentioning. One of them is the westernized adaptation of ethical practices, which also probably is not taking into consideration the context that I described here, and the fact that these curricula or training programs still do not exist within formal education systems. So, yes, we need to adapt more contextualized models. How we can do that potentially will need to also take in a lot of experience from the field and from the ground. So bringing in more field experience into the theoretical work and theoretical teachings of students as well is important. Even simulation of these contexts as part of learning and training and educational programs is important. Not just reading about how we are going to do this in books, but to get students to go through these situations in a safe in the safe environment of the teaching, but also to prepare them so when unfortunately these contacts happen, because we are living them and they don't seem to be going away, and how to be able to be well prepared, because we know that ill preparation also puts students and junior mental health professionals at a higher risk of moral injury and burnout if they have not experienced some of this context in the safe environment of the university and their coursework.
Am I allowed two questions, or can I ask just one? Okay. My question is for Bert and Parth and the colleague who presented on lived experience. I think from what you're saying, WHO in developing the framework has not engaged lived experience in the development of their policies. So that is a reason why you have to do this whole thing, about looking at whether their policies are relevant to the people with lived experience. So my question is, what are the opportunities and barriers to lived experience engagement while developing these policies in the first place? And do you have any thoughts and recommendations on that?
Absolutely, thanks, and I can also give it to Julia. I'll just answer one question before that also. I just wanted to spotlight when you were talking about task shifting that actually during the pandemic there were examples of reverse task shifting where psychiatrists had to be taught psychological first aid for pandemic preparedness across different contexts. So it was in fact peer support workers were teaching them about queer affirmative work during the pandemic, caste affirmative work, race affirmative work in different contexts across the world. So that's a fantastic point that you brought up. And there's actually evidence that's being developed around reverse task sharing or a more democratized version of that. So just want to point that out. Okay, to your question specifically, I think, no, we're not claiming that the WHO did not do that. That's not the claim of this particular project. The WHO has created a framework in 2023 for the meaningful engagement of people with lived experience in non-communicable diseases. That was done. We have a lot of people here from lived experience who are in fact on that particular policy document. Our presentation was more so about holding systems accountable, to say that you are working in silos as an international organization from a very top-down approach. Regardless of whether or not you have a personal lived experience on the board, that's not a monolithic representation. We're already running the risk of co-optation and participatory assimilation within this space, which means that you can have one person with lived experience on a WHO board to get one policy out. That doesn't still represent the larger frameworks across the world. So what we're trying to say is we need to move research to more grassroots spaces. We need to do a lot of research and counter resistance to existing organizations and hold systems accountable and say that this is our version of giving you a white report, a white paper, and saying, see, this is what we have gathered from our communities. Your policies don't translate, regardless of whether or not you've had lived experience on them. I hope that made sense.
So the reason that the project actually began in the first place was that the WHO had actually approached us to complete this research to ensure that it is fit for purpose, it's meeting all of the needs of service users, of systems, to ensure that they're going that